welcome. Welcome to another VMR Thursday. Today I'm so excited because I will discuss with my friend Rabih, and I hope learn a lot. And Rabih, how are you?
Oh, I told you, I'm so excited for so many reasons, but today we have, I think, round number 3 or 4 of an amazing human being who has superseded their vulnerability. Of course, it's always a little bit intimidating to present on the stage, is powering through that and is here presenting with us. And I'm really excited because I'm co-discussing with the co-leader of the case review committee, along with Umaima. Amanda is here to co-discuss, and I'm really, really grateful for all the work the team is doing behind the scenes to help our beloved John make it here today. John, do you want to introduce yourself to the crowd?
Sure. Hi, everyone. My name is John Romero. I'm from the Philippines. I'm currently an extern at MedStar Franklin Square here in Maryland.
Tell us where in the Philippines.
I'm from Cebu.
From Cebu. Where is Cebu?
Centrally located.
Centrally located.
Smack dab in the middle.
In the middle. Can you share with me, how long have you been in Maryland now?
I want to say 2 years, maybe.
Oh, 2 years. Wow. One of our role models, really, Rabih, who I don't think I see. He usually joins on Thursdays, but may not be able to make today. Is actually, oh, there he is. Hi, Rabih.
How are you?
Did you hear that? John is hanging out in Maryland.
Oh yeah, you remember Dr. Williams, my program director?
I think I see Dr. Williams here today.
Yeah,
Him.
he's working with him as well. So
no way. That's so cool. Hi, Richard.
Hello. Great to be on board here. Yeah, John said he was presenting today. I said, John, I'll see if I can be there.
Oh,
And-
amazing.
Dr. Williams.
Hey, Rabih.
how are you, Dr. Williams?
Good as far as I know.
Humility, even in the state of being. I absolutely love it. Well, we're really, really excited to have all of you here today, and really excited for Amanda, who's 4 cups of coffee deep for this case. All right, John, take it away. As a warning, quote unquote, to you all, we'll do a breakout room. So please, join if you can. If you would rather hang out in the main room with Amanda and I, it's no problem at all. But I am excited to help all of you guys feel more comfortable by getting to know each other, kind of in the middle of the case. We'll find a good time when John has built up the tension to jump into breakout rooms. All right, take it away, my friend.
All right. So our chief complaint is nausea and vomiting with hematemesis and dizziness.
Okay, can I start? Nausea, vomiting, hematemesis, and dizziness. So when I see the chief complaint, I'm worried because of the hematemesis, because can be a cause, a pulmonary cause, and dizziness too, because maybe some neoplasia or some malignancy. But the nausea and vomiting, it's maybe not, it's important, but not. I prefer to talk about the hematemesis and dizziness, but I think about pulmonary causes.
Amazing. Amanda, that's absolutely superb. You taught us something really, really important here, which is, how do you choose between which chief concern to focus on? And you said nausea and vomiting not as important as blood coming out of a person. 100% correct. I completely agree with that. I'll just make one clarification, that when we use hematemesis, it means the blood is vomiting. So it suggests that the blood is coming from the stomach or the GI tract. So have you taken care of a patient in real life, Amanda, who was vomiting blood?
Yes, with ulcer.
With ulcer, yeah.
Yes, I really saw this case. But when here, almost in Brazil, when say vomiting, when is blood vomiting, it's one thing, and hematemesis it's other thing.
100%.
I think the hematemesis is more from pulmonary cause. In blood, vomiting or vomiting with blood is from GA cause.
Yes, 100%. I think that all you really know now for sure is that something red is coming from the patient's mouth. You don't know if that red thing is blood, and you don't know if that, whatever it is, if it's coming from the upper airway, from the lungs, or from the GI tract. So only when you witness it with your own eyes, if the patient coughs and then something comes up bloody, then it's hemoptysis. If the patient has bleeding in their nose, then it's upper airway bleeding. Or if the patient vomits and comes blood, then you know. But let me tell you why I'm pretty confident this patient is having stomach bleeding. Dizziness. There are two causes of dizziness: lightheadedness and vertigo. In the setting of volume loss, lightheadedness becomes a very decent assumption. Here's an interesting thing about hemoptysis. It's very unusual to have bleeding from the lungs so much that the patient feels dizzy. Why? The patient usually feels short of breath well before they lose enough volume to become dizzy. So if you lose 20% of your blood volume to become dizzy from the lungs, you will need to be intubated first. You can still lose a decent amount of blood from your upper airway, like your nose and your posterior pharynx, without any compromise. So there's a small chance this person has upper airway bleeding, but by the time it's this profuse, there's usually issues with airway protection. So I would say, because there appears to be a significant amount of bleeding as evidenced by the dizziness, the place where you can bleed the most without something else stopping the degree of bleeding, like dyspnea from hemoptysis or aspiration from blood in the upper airway, prioritizes a GI cause. And you said it, the most common cause of GI bleeding is an ulcer. So Amanda, I'm curious. I want you to close your eyes, real life, and just picture this patient is in front of you right now. What do you want to do next?
So I think like you say, the dizziness maybe of the cause of hematemesis, so maybe a shock. So I will start with fluid.
Excellent.
And primary access to the patient is giving her fluid.
100%.
Or her.
Amazing. You need to get very good IV access in this patient, and Yusuf's VMR on management reasoning has a great tutorial on the types of IV access, but this patient needs very good IV access. And even before you know any information, Amanda, what do you think you will ask the pharmacy to give you? Fluids? What other things will you call pharmacy to help send you from a medication perspective?
Omeprazole.
Amazing. So PPI like omeprazole. Here you'll probably need to use it IV because of the hematemesis. Excellent. Can you imagine any other medication maybe in this person's future?
Maybe some package of blood, because I don't know if the patient needs.
100%.
And I think it's omeprazole and blood, sangue.
Exactly. I want you now to tell you that your answer is excellent. And I think you'll see one thing on the physical exam when we get there that might add something else also, but we'll wait and see, okay? So right now, let's call the fake pharmacy and say, oh, can you give us some PPI and get some blood ready? We will discuss in a little while what other medications you might use and how you decide blood or no blood. We'll discuss that later because I think we can talk forever. So John, I'll give you back the mic and tell us what you have next.
Sure. So for the HPI, so 2 days prior, he was celebrating his child's first birthday, and he stated that he'd been drinking a little bit more than usual. 1 day prior to admission, he decided to stay home since he was having a bifrontal headache rated at a 2 to 3 out of 10. He took over-the-counter aspirin and decided to stay home to nurse his hangover. Morning of admission, he noted a sharp increase in pain with his bifrontal headache. He took over-the-counter Tylenol with not much relief. He also noted the onset of dizziness and nausea and vomiting. He had 3 episodes of vomiting, with the first 2 consisting of previously ingested food and the third with frank blood. Then he was rushed to the nearest ER.
Amanda, he's like a professional presenter. Wow. Wow. I'm so glad Dr. Williams is here to see how amazing you're doing. This is awesome. And hundreds of people on YouTube later, but no pressure. I'm just kidding. I'm just kidding. Amanda, what do you think now?
So I think I'm worried because of the usage Tylenol, and I think it's a common cause of ulcer. It's the abuse of the non-steroidal hormones. And I think the vomiting is persistent, and maybe the vomiting can be too because he eat poison food, blood, apesar do blood, but I think it's that.
Yeah, you know, I think, Amanda, it's interesting. So it's very common for aspirin and Tylenol to be lumped together as over-the-counter medications. Tylenol or acetaminophen, thankfully, does not cause ulcers. Aspirin, however, causes as a high rate of association with ulcer. So that's the non-steroidal anti-inflammatory that should make us very worried that he might have complications of that in his stomach. I'm curious, what do you think of the history here? First, vomit without blood, and then afterwards, blood. What is that? Does that help you in any way, or is that not very helpful to you?
I think can be means like a gravity. So with not blood, it's little gravity, and with blood, it's some complication in something grave.
Exactly. The presence of blood is almost certainly a complication here. Excuse me. This is my Zatar talking. Have you heard of Mallory-Weiss tear? So this is good. This is good because I think it's important to think about it here. Mallory-Weiss is a disease, a syndrome, probably named after 2 doctors, Mallory and Weiss, but I'm not sure. And what happens is this, Amanda. You vomit so much. And as a result of vomiting, you cause a tear in the distal part of the esophagus. So here it's now very interesting, Amanda, because we have to solve the problem that's not GI bleeding. We have to answer the first question, which is, why was he vomiting so much that caused a GI bleeding? So if you think about this case, first we were like nausea, vomiting, and you said very correctly, I don't care about nausea, vomiting, this person is bleeding. But now, because of the sequence of events, first nausea, vomiting alone, and then bleeding, we now have to change. Because first he vomit without blood, and now he's bleeding. So the real problem becomes we have to manage the complication of bleeding, but we still have to have our energy focused on the underlying core problem, which is, why did this person start to have a lot of nausea and vomiting in the first place? And also, anytime anybody has a Mallory-Weiss tear, we also have to worry, could this small tear that's just causing bleeding become a complete tear of the esophagus, resulting in what's called Boerhaave syndrome? So this goes to show you one thing, Amanda. The sequence of the story, how things happen in order, is very, very helpful. So now, I think it's still omeprazole. Still think about blood, but now you have to solve nausea, vomiting separate. All right, John, tell us more.
So for past medical history, he has rheumatic heart disease, status post AVR with a bare metallic stent 2019. He has cardiomyopathy with heart failure with preserved ejection fraction, and he is hypertensive. For social history, he is an occasional social drinker. He states that he drinks 1 to 2 beers at best with his wife on the weekends. He is a non-smoker and no history of illicit drug abuse. He has no known allergies. For home medication, he's taken warfarin 7.5 once a day. Also like to add that he stated that he had difficulty monitoring his levels due to insurance issues. He's taken aspirin 81 once a day. He's taken Entresto 2426 milligrams, 1 tab twice a day, metoprolol 25 once a day, spironolactone 25 once a day, and Veroquo 5 milligrams twice a day.
Hey, John, can I ask you before to give Amanda some time to think? How are you feeling now compared to how you started?
I feel excited.
Yeah. What do you think changed?
I think just getting in the swing of things.
Yeah, you get like kind of in a rhythm now, huh?
Yeah.
That's awesome. I'm so glad to hear that. Wonderful. Amanda, see, I bought you some time there for free. What do you think?
So I think the past medical history of the patient worries me because a lot of complications of the rheumatic heart. And I don't know if the medications like the warfarin is involved with the vomiting of the patient, in the almost because it's the difficult vomiting levels. And I don't know, something of the heart can cause vomiting and with bleeding,
Amazing. I love that. I'm going to let you keep thinking about that. And I only have one question for you. Today is Rabih asks Amanda questions today because she's too good. Can you think of another medication you can need to call pharmacy? You said first blood, PPI, any other medication now that you might need from pharmacy?
Thrombin, I think it's
Yes.
thrombin.
So you're thinking now, reverse the anticoagulation.
Yes.
And the way you do that with vitamin K, with warfarin, is maybe vitamin K and maybe some blood products, which we don't have time to go into detail about. Deciding whether or not to reverse a patient is a function of two things. One, how badly is the bleed? And what is their risk of thrombosis? This person who has a mechanical valve has a decent risk of thrombosis. It's higher when the valve is in the mitral position than the aortic, but it's still something you have to always think about. So we need to now quickly assess how bad is the bleeding. Is it just a little bit of bleeding and mostly nausea and vomiting, or is this patient really, really bleeding? So that will also influence how we do. If this patient just had atrial fibrillation on Coumadin, then the risk of thrombosis is low for most patients with AFib. But this person has a prosthetic aortic valve, which confers a higher risk than other things. So you're right. Now you have to call pharmacy and say, maybe I need to reverse the warfarin. So now you have three things. Maybe there's a fourth. We'll see, depending on what John tells us next. Go for it, John.
Yeah. So for physical exam, his vital signs are as follows. Temperature is 36.7. Heart rate is 56. Blood pressure is 131/77, and he's saturating at 98%. Our 31-year-old gentleman appears comfortable. He's well-developed, well-nourished, no pallor. For his eye exam, pupils were equal, round, and reactive to light bilaterally, and left unilateral nystagmus was noted. He was not in any respiratory distress. His lungs were clear to auscultation with good air exchange. He was bradycardic on his cardio exam. And then for our neural exam, he was oriented to time, person, place, event, and situation. His extraocular motor muscles were intact. Pupils were reactive and symmetric. Left unilateral nystagmus is noted. No visual field defects. No facial asymmetry. Tongue is midline. Facial sensation is intact bilateral. Speech is clear and not dysarthric. Finger to chin is intact. No pronator drift. And maybe a slight overshoot is noted. He can perform heel to shin, and he can perform rapid alternating movements. Unsteady gait is noted when he is ambulatory.
Amanda, I'm now really, really worried.
Yes, me
By the way,
too.
did you notice how John is paying attention to the chat and said this 31-year-old man, because the chat was asking his age? Elite level, my friend, elite level. Thank you. I can't believe this is your first case presentation. You clearly have had a lot of time to practice the skill, but I'm really glad that we get to benefit from it today. Amanda, where is your head now?
A lot of place, but the pulmonary and abdominal okay comfort me, and the bradycardia can be because of the metropole use, but worries me, and the vomiting the patient and the diseaseness the patient can be a cardiac cause. I'm thinking maybe some arrhythmia, and maybe one AKG help us to find one of these ashes. And I don't know if can cause, but tamponade, cardiac tamponade can be the, I don't know if can be the vomiting with hematemesis or in diseaseness.
I absolutely love your thinking, my friend. And I really believe we have arrived at a tension point in the case, because I think right now, my dear friend John just threw us a curveball, and we have to be very careful not to make a mistake. So let's go into breakout rooms, have everybody slow down, because this is a very critical juncture in the case, I promise. So I'll open the breakout rooms. We'll be there for about 5 minutes. And if you'd prefer just to stay in the large group, please do so. Take your time to think and put yourself, if you're on YouTube or in the large group, really, really, really ask yourself, what testing are you going to do for this patient? Okay, and we'll be back and continue the discussion as a large group in about 5 minutes, okay? Okay.
Hi guys, doesn't anyone want to talk about the case?
I am super confused. In the beginning, I confused hematemesis with hemoptysis. I think this because I am anxious. And here I didn't see the nystagmus and the hell to team. So makes maybe change what I was thinking.
Yes, I was gonna say that we didn't miss that, but we forgot a little bit about his headache in the beginning of the case, and now he appears with a lot of signs in his neuro exam. I was wondering if maybe he could have a CNS hemorrhage because of the warfarin. What do you guys think about it? I think we definitely should order a brain CT.
Yes, I super agree. I was thinking too because arrhythmia can cause these symptoms too, like a headache, dizziness, and can be a nystagmus, and makes me worry. I think the EKG and the CT of the brain CT, it's very important here.
Yes, I think it's important because we have to rule out like the most important things, and after to start to think about like mild conditions. So I think John could help us here. John, are you here yet?
Hi, sorry, I stepped away. What was the question?
No, I just we were talking about headache and neuro signs in the physical exam, and I said that maybe you could help us here what we should do.
Oh yeah, you guys were in the right track.
Oh,
Oh,
this is a good
this
point.
is good.
Thank you.
Alrighty, folks.
You're welcome.
I'll let everybody back in, okay? Thank you, guys.
Okay.
All right, Amanda, we can wait for everybody to join back from the breakout room. And you can share your thoughts now that you have some time to think. I'll let you know when everybody's back, okay?
Okay. I am confused everything I was saying.
Good.
I
Good. That means that you're in VMR growing. You know how after you do a workout and exercise, you feel a little tired, and that's what confusion is. Your brain is working very, very hard to try to figure it out. Don't worry. John is here as master case presenter. We'll give you more information to help you narrow it. But I think, Amanda, I think everybody is back now. So what are your, now that you've had some time to think and talk with the brilliant Mariana, what do you think now?
I think that we will pass the every organs in the body. It's GI, heart now, the neuro confuse me. But I was thinking about arrhythmia, and I didn't see the unilateral nystagmus. And I was talking with Mariana, it's because the heartache. We don't think about the beginning. The patient had heartache, and I'm worried if because he have brain disease and he used warfarin, so it makes me worry, like a blood in the cerebrum.
Beautiful. I completely agree with you. I think if you just analyze this case, and try to repeat what happens in real life, and try to use this case to get better in real life. You hear the words, maybe before you walk in the patient room, the nurse comes to who's triaging the patient, or maybe calling you, says, hey, I have a patient who has nausea, vomiting, and just vomited blood. He's also dizzy. Immediately, you should think GI bleed and hypovolemia. But you should never, ever put anything in concrete, rock solid. It should always be fluid. So especially early. And then you go and you talk, you say, hi, introduce yourself. And then he says, oh, no. First, I got nauseous and vomited. I got nausea and vomiting. And then I had bleeding. Oh, by the way, I have a headache. We're like, oh. And then immediately, a brain bleed doesn't become likely, but then you got to be like, okay, let me do a quick exam. In the next, you should do an exam within 2 minutes of seeing this patient to establish the most important thing in this case, which is, what does the dizziness represent? Because your initial assumption is to take dizziness and immediately assume it's intravascular volume depletion. But if you do an exam in this patient, you'll see the heart rate is not high and the blood pressure is normal. And you can probably do a quick volume exam and see he's probably not volume depleted. And then you start to notice, ooh, nystagmus. Then you start to notice he can't do heel to shin. And I would become really, really curious. And I would ask him one question. How did you get here, sir? How did you arrive? Were you able to walk? Because if he cannot walk, oh my gosh, the possibility of vertigo as the central vertigo as the explanation for his nystagmus and his neurological findings would skyrocket. So I'm curious, John, I know that in most circumstances, these patients are admitted and you may not know how they arrived, but did you just happen to know how he arrived into the emergency room? Did he walk by himself?
His wife was with him, so he was driven by his wife to the ER.
Got you. Yeah. See, you can see how that information is very, very helpful, that this person is not comfortable driving himself. And that's very, very illuminating. So what's my piece of advice? My piece of advice is twofold. First, you have to translate the non-specific symptom of dizziness into something else, always. And you translate either dizziness to orthostasis or dizziness to abnormal eye movements, always. So when you hear dizziness, within 2 minutes, you need to take dizziness, delete it, and say either orthostasis or abnormal eye movements. Every time. If somebody says the word dizzy and they're not orthostatic and they have normal eye movements, then they're telling you something else. They're not telling you hypovolemia and they're not telling you vertigo, which is common. Many cultures use the word dizzy to just mean they're not feeling good or healthy. So there are 3 possibilities for this patient who's dizzy. He's just using the word dizzy in a non-specific manner to convey not feeling well, or he's orthostatic, or he has vertigo. And we have now proven he has vertigo. Not only does he have vertigo, he has findings that are concerning for cerebellar pathology, which is the inability to perform heel to shin. So this immediately becomes an acute cerebellar syndrome until proven otherwise. And acute neurological syndromes should be assumed to be vascular until proven otherwise, either a stroke from his rheumatic heart disease, because we learned earlier, an ischemic stroke from his rheumatic heart disease, because we learned earlier that he has inconsistent use of his morphine, maybe he's subtherapeutic, or he has a hemorrhagic stroke from taking too much Coumadin. And now here's the real problem. The presence of a headache is very unusual in the face of an ischemic stroke. It might occur if somebody has an ischemic stroke, has vasogenic edema, and that edema causes pressure. But I think you have to really worry that the bradycardia here and the headache signify clues for the possibility of intracranial hypertension. So I really, really worry about a brain bleed in this person and would tell you that a CT may not be perfect for a posterior fossa bleeding. So even if John tells us the initial CT is normal, you still have to hold on to the possibility that there might be an image negative posterior fossa bleed and repeat the CT in a little time if he continues to feel this poorly. So this goes to show you how powerful the exam is in a patient who's dizzy. Immediately translate dizziness into orthostasis, which is what we were expecting, But this time we were wrong. It turned out to be vertigo. And you cannot be wrong for too long. In real life, you should only be wrong for a minute or two. All righty, John, tell us more, please.
So for our labs, he has a white blood cell count of 9.5, hemoglobin of 14, hematocrit of 38, platelets of 165, an MCV of 85, neutrophils at 88.7. His creatinine is at 9.9. PT is at 36.9. INR is at 3.7. His sodium is at 144, potassium at 4.4, and glucose at 143.
So Amanda, the INR is high. I think we learned. Yeah. Any other thoughts, my friend? I think you're muted, Amanda.
No, I'm just thinking because I think what is alterated here is the ENR
Yes.
and probably because of the warfarin.
Yep.
Yes, it's just it.
Yeah. And now you have to call pharmacy for sure, because you need to reverse this you'll know for sure in a second when you get a head CT if this is a bleed or not. But now I call pharmacy and I have the medications ready. 3.7 is not very, very high, but if the person is bleeding, you need to make sure it doesn't go higher and fix it right away. So yeah, now we're calling in that third medication for sure. All right, John, tell us more, please.
Yeah, those a CT was actually done, but I'm on my phone, so I don't know how to share the image.
Oh, that's okay. You can just share the result. Yeah, I don't think you'll be able. I'm trying to think. I don't think you can share it on. I don't think you can share it on. Yeah, you can say that again.
I asked Umaima to.
Oh, there you go. Sorry, I just missed that on my mom. Sorry. Let me make you co-host. Yeah, let's do it. Thank you, Umaima. 3, 2, 1, and now you have all the powers in the world, Umaima. I think, Amanda, we're on the right track if Umaima's sharing this CT from John. So hopefully it's maybe they're giving us practice reading a normal CT. We'll see.
It will be an obstacle to speak in English and see a CT, but let's go.
All right, there you go. I think you'll got this. Also, look how much reading and Umaima is doing on all the tabs you have there. Amazing, Umaima. Wow. All right, what do you think, Amanda? What do you see?
I don't know if the black part here it's ischemic, but I think I see a lot of blood. It's very white.
Yeah.
In the upper.
Yeah, agreed. Yeah, I completely agree with you. That part, the white part in the middle of the left in the medial aspect of the left cerebellum is very, very concerning for bleeding. Yeah. Yeah, John, maybe you and Umaima can walk us through what you thought this was and what it represented.
Yeah, so with this, the bleed was much more exquisite on the actual CT, but this was the maximal point of the bleed. So let's start with locations. We're a little bit below or at the base of the brain. As you can see at the front, we have the nasal sinuses and the eyes and everything else. But the actual read is acute parenchymal hematoma in the left cerebellar tonsil, measuring approximately at 2.1 by 2 by 2.5, with mild mass effect on the inferior aspect of the fourth ventricle.
Thank you, John. I just messaged Umaima in the chat. I'm not sure if you can. Do you mind just pointing it out with your mouse just so folks are clear, if you're able to? No worries at all. Thank you so much.
Yeah, that little white blob.
Yeah, right there. Yep, exactly right. Yeah. So folks, I think we should take 1 minute to share your thoughts in the chat about one really important thing, which is well, actually two things. What do you think about management? So what would we do for this person? And then what do you think the cause is? So Amanda, while folks are sharing in the chat, what do you think, what do you know about treatment for acute intracranial hemorrhage?
Surgery.
Surgery is one option. Anything else?
I descompression, derivação,
Yeah, to remove
I
the
don't know how
No, I know.
translate to
to
English.
work, you have to do things to remove the pressure, for sure.
Yes,
Okay.
like a DVT. Here we
Yeah,
speak
remove it.
like that.
How do you think you can control the bleeding? So pressure, you can do craniotomy is one option. How do you think you can stop the bleeding?
Giving like this medication. Let me, I know.
Take your time.
Transamin.
Yeah, there's a lot of basically medications to stop the Coumadin effect. Blood
Yes.
pressure is really important here. What do you know about blood pressure here?
Blood pressure.
Do you want it to be high, low, or normal? What do you think?
It's low. No?
What do you want to do for management? What do you want to keep the blood pressure?
High. We have like 180 to 2000, I think.
Yes, you're right that when a patient has ischemic stroke, when the patient has ischemia, you want to make sure the blood pressure is not too low so that the blood can go there. In hemorrhagic stroke, you have to do something different when there's bleeding, because if the blood pressure is high, you make more bleeding. Exactly. So you have to lower the blood pressure significantly in this patient. Thankfully, his blood pressure is normal. So what do? You have to stop the bleeding and reverse the Coumadin. In this patient, in many parts of the world, you would give vitamin K and you would give something called prothrombin complex concentrate, PCC, to reverse the effects of the Coumadin. You would then manage the blood pressure and lower the blood pressure, and it's your target changes with every day of what the blood pressure should be. And then you try to reduce the pressure in the brain with either medications like mannitol, positioning, upright positioning, a trial of hyperventilation, and in some cases, a craniotomy. So this patient is very, very sick. And the question is, what caused this? So there are really 4 common causes of spontaneous non-traumatic intracranial hemorrhage. However, we should first do some practice and be clear about what we mean when there's bleeding inside the skull, because it depends where the bleeding is on what the cause is and what the management is. So you can bleed in the epidural space, usually as a result of trauma. You can bleed in the subdural space, also a result of trauma. Those are bleeding outside the brain, epidural and subdural, in the coating of the brain. Then you can bleed in the subarachnoid space, usually from aneurysms. Then you can bleed inside the brain, intraparenchymal, and you can even bleed in the ventricles, intraventricular. So if you go from outside, you go from epidural, subdural, subarachnoid, intraparenchymal, intraventricular. The causes of, there are 4 common causes of spontaneous intracranial or intraparenchymal hemorrhage, I should say, intraparenchymal. Hypertension, which usually occurs in the deep brain matter, including the cerebellum. A cerebral amyloid angiopathy, usually in older adults and usually in the cortex. Coumadin related or anticoagulant related, and then bleeding from an underlying mass, like a cancer can bleed. Here, the location of the bleeding is certainly related to Coumadin, but you also wonder if the patient's hypertension is also contributing given the location of the bleeding. Because if this person was not on Coumadin and you saw this CT, you would call this a hypertension related bleed. So I wonder if it's both contributory in this setting. But I've said a lot. I'll pass the mic to you, John, to tell us what you were thinking and how you managed the patient and what happened.
Yeah, so he was transferred to our hospital for a suboccipital craniectomy watch just because of the location of the bleed. And if you do block the fourth ventral, you get non-communicating hydrocephalus. So that was important. But his course throughout the neuro ICU was very benign. CT scans taken at 6, 24, and 48 hours showed no expansion. MRIs did show a little bit of microbleeds, but we were thinking it was because he was on warfarin and his controls were a bit iffy. His angiogram was beautiful. There was no AVM, and he was downgraded after 2 days. A GI consult was not done because his H&H was virtually stable. Generally, how we managed him here was we kept his blood pressure at 140, below 140 as best as we could, which was fairly easy because when he came here, he was already at 130s. And then he arrived here already reversed. His anticoagulation was reversed with vitamin K, fresh frozen plasma, and PCC. And we just made sure to watch his intracranial pressure, his glucose, his temperature, and we started with early mobilization and rehab.
Absolutely amazing. It's incredible that such a devastating thing can have such a great outcome sometimes. That's wonderful to hear.
Yeah,
so you were rotating in the neuro ICU? Is that where you were, John?
Yeah.
Oh,
and what was funny was at the same time over at the med surge, there was a lady who had an INR of 10 and she didn't bleed in her brain.
Yeah.
This guy had an INR of 3.7.
And did.
Amazing. Yeah.
It really is very, very humbling. I'm curious, what was your experience like taking care of this patient? What did it feel like?
It was a little bit scary in a way because he was just a regular old guy, a regular dude, 31, hanging out with his kid, and all of a sudden he bled into his brain. Like, that makes no sense to me.
Yeah, I think that like all these things are very, very tricky, and that's the power and the value of the direct acting DOACs that carry a much lower risk of intracranial hemorrhage, including some other things that this patient may have had. How was the experience like going through the case review committee and presenting today? What did that feel like?
Oh, it was fun. So like when I drive to work, I listen to podcasts. There was one podcast titled Brainwaves by Dr. Siegler. He talks about the art of the pivot, where I got to see it firsthand here, where when hematemesis was put out there, everyone was chasing a GI problem. And when we came to the physical exam down to neuro, everyone slowly pivoted. It was a beautiful thing. It was great.
100%. Only pivoted because of astute observations, right? Like these are not, how many people, can you easily imagine a situation where you hear the word hematemesis and you don't do this neuro exam easily?
So 100%.
Right? Yeah. Really, really amazing case. Very educational, John. Thank you so much for presenting it. We really hope that you join us and we see you more often. We have a lot to learn from you.
Likewise.
Amanda, how did it feel?
I am tachycardia.
Why?
Thank you, John, for the case.
You did great.
And it's impressive, like when learn a lot with discussing a case. And thank you, Rabih, to ask me questions.
Many questions.
Yes, but I think I prefer questions than discuss. So I love this model that you do. And so thank you.
Yeah, Amanda, I love to ask questions because I think that the whole point of this community is to actually not pretend like we all know everything. And I started to do something new on my team with my team in my hospital, which is when they present, I asked them to tell me three things they did wrong in the case. Because I guarantee you, every single patient you take care of, there's 2 or 3 things that you wish you would have done better every single time. And so for me, Amanda, being able to ask you questions and for you to showcase your growth live in front of all these people is incredible. And I think that's what it should be like. And I can already tell you the 3 things I did wrong is I assumed hematemesis was the center of this case. I assumed the dizziness was hypovolemia. And then I assumed that the bleeding was from Coumadin. But I think the hypertension might have played a role here, especially with just an INR of 3.7. It's like those are 3 mistakes that I made, and there's probably even more that I made. And so I encourage all of you to push yourself to get more and more comfortable, to not try to aim for that 100% that all of us are pushed to aim for all the time to be where we are, but to also at the same time figure out, okay, like, where did I go wrong? And you'll learn a lot from that approach. And I appreciate you, Amanda, for modeling it. Okay, last but not least, ferociously working at Teaching Points. David, can you take it away, my friend?
Hi, and thank you for the case. And I can tell you, 4 days ago, I've seen a patient just like this in the ER who came also with nausea, vomiting, and dizziness, and had also a cerebral bleeding. So the great case. This case started with a patient that presented with nausea, vomiting, and hematemesis, and hematemesis was the bleeding symptom, and the diagnosis has to rule out measures such as hematemesis or ENT bleeding, and the DBX depends on the patient if the patient is cirrhotic or not. In this case, dizziness made us prioritize hematemesis more than other causes such as hemoptysis or ENT bleeding. That pearl that Rabih shared, that we have to translate dizziness into orthostasis or abnormal eye movements to try to know if there's more kind of vertigo or pre-syncope. The immediate management in this case passed through getting 2 large IV access, PPI, fluids, prepared blood products, and depending on if the patient has cirrhosis or is on anticoagulation, or if he could need a massive transfusion protocol, we had to think of that, to ask for reverse agents and all of that. In this case, the headache, and the physical exam that revealed unsteady gait, dysmetria, and nystagmus made us thinking central vertigo as the pivot point of the case, and this is translated into acute cerebral syndrome that in a patient with on anticoagulation, we have to rule out bleeding. The other possibility is ischemic stroke. It's more difficult to diagnose as the CT and the angio-CT has less sensitivity to the posterior fossa lesions. The headache and the bradycardia were close to the bleeding in this case, and you have to think of the management in a case like this with controlling blood pressure with an objective of systolic blood pressure between 110 and 140 milligrams of mercury, and control also the glucose, the temperature, see if he needs, if the patient needs reverse anticoagulation, and think of the treatment of intracranial hypertension with head elevation and hyperventilation or mannitol, and consult the neuropsychiatrist. And after that, we should think of the causes: hypertension, AV malformations, pharmacologicals. There are a lot, but in this case, the main possibility is the anticoagulation given the patient past medical history. So, thank you very much.
That was amazing. I mean, so concise and so to the point. Thank you so much. Thank you to Amaiman and Rabih for reviewing John's amazing case. John, there's a demand that we see you frequently in VMR in the chat. I'm not sure if you saw it. And I would just say that, gosh, if I had a residency program, I would invite you to join it just based on your hour today. So maybe we should start a CB Solvers residency program. Yeah, really appreciate you being here, and I appreciate you, Amanda, for jumping in and discussing this incredibly important case, an interesting case. I hope some of you have been inspired to present yours and to continue our collective learning. And John, don't forget to put this on your CV. It's really important what
I
you
will.
just did.
I'll,
What's that?
I'll be back.
I look forward to it. All righty. Bye, y'all. Have a great day.
Thank you. You too.